Welcome to our inaugural Healthy Brain Research Network Scholars Webinar. My name is Basha Belza, and I'm lead of the Coordinating Center for the Healthy Brain Research Network. Our plan today is to start the webinar with telling you a bit about who and what the Healthy Brain Research Network is, and then we'll hear from our very own three speakers, all the members of the Healthy Brain Research Network. And then after each speaker, we've invited one of the scholars to serve as our initial responder, and then we'll have time for questions and answers before we move on to the next speaker. For attendees on this call, if you'd like to ask a question or make a comment, we would invite you to add it to the chat box located on the left of your screen, and then I, as a moderator, will be able to share that with the group. Due to a number of requests, we will be recording this webinar and making it available to all of you and your colleagues. So first of all, let me tell you a little bit about the Healthy Brain Research Network. We are a thematic network of the CDC Prevention Research Centers program, and we're funded by the CDC Healthy Aging program. The Healthy Brain Research Network is composed of the Coordinating Center here at University of Washington and 5 member centers located at University of South Carolina, University of Pennsylvania, University of Arizona, Oregon Health Science University, and University of Illinois of Chicago. And our mission is really fourfold. One is to establish a public health research agenda that promotes cognitive health, addresses cognitive impairment, and then helps meet the needs of caregivers. Second, we build a strong evidence base for policy, communication, and programmatic interventions. Third, we collaborate with public health agencies and partners to accelerate effective practices. And then 4, we build the capacity of public health professionals through training opportunities. And it is really through this last mission statement that really moves us to our webinar today. And so one of our cross-network efforts is our scholarship program. And each of the Healthy Brain Research Network member centers provides a range of opportunities for student involvement in public health education and research. And the scholarship program introduces students at all levels from a variety of disciplines to aging and public health. And today's webinar was designed with input from our scholars. So I wanted to offer my very warm welcome to each of you, to our past as well as our current Healthy Brain Research Network scholars, and all the many guests that have joined us today, including our CDC partners as well as other community partners. At the end of this webinar, you will have the opportunity to complete an evaluation, and we'll send you a link in next couple of days inviting your feedback. So please make note of the things you really like as well as the things that we could change, and that will help inform our future webinars. So it's my pleasure now to welcome and introduce our very first speaker, Dr. Jason Karlawish. Jason's a professor of medicine and medical ethics and health policy at University of Pennsylvania, and he is with the Penn Healthy Brain Research Network. So welcome, Jason, and we look forward to your presentation.
Well, thank you, Basha. It's a pleasure to be here. I'm Jason Karlawish, and I'm talking to you from my desk in my office at the University of Pennsylvania, where I'm a faculty member in the departments of medicine, as well as medical ethics, health policy, and neurology. And I also want to thank Gwen Moni for organizing this event and making it all come together. So real pleasure. So my talk is to answer the question, what is cognitive aging and how is it different than dementia? So it's a talk on definition. It's important to know what something is if you're going to be able to tell people what they should do about it. So that's my mission. So maybe I'll start with the thing that it's not, which is it's not dementia. So dementia defined describes a syndrome that is the result of at least 6 to 12 months of progressive losses in cognition that are causing someone to be disabled because those cognitive problems are interfering with the person's ability to do their usual and everyday activities. So based on whatever baseline they were at, now because of cognitive problems, they're no longer able to, say, cook a meal, manage transportation from one place to the other, pay bills. Dementia simply describes the severity of a cognitive problem that meets these other features. Behind it, of course, is a cause, and there are multiple different causes of dementia. The most common causes are neurodegenerative diseases, and the most common neurodegenerative disease is Alzheimer's disease. Other neurodegenerative diseases that cause dementia, and for example, Parkinson's disease, classically I know thought of as a movement disorder, is also now understood, well understood, to be a cause of dementia, particularly in individuals who develop Parkinson's disease after their 6th or 7th decade of life. So that's dementia, well understood, well reified concept in the culture. So what's this idea of cognitive aging? Well, let me just start with the phrase at the bottom of the slide. It's sort of everything that's left over after you take disease out of the mix. And I'll explain more what that means. But what we're talking about are the gradual longitudinal changes in cognitive functions that accompany aging. So if you take a group of older adults, or let me back up. If you take a group of adults and you follow them along every year, measure their cognition, but being careful that first you examined each of them and removed anyone who you felt had a disease that would impair cognition, whether that's Alzheimer's disease or perhaps mental illness, etc. Remove all those individuals and then measure their cognition every year. Whatever change you show, or changes that you don't show, in other words, no change, but whatever you show over time is essentially defining aging. So take away the diseases, what's left, that's aging. So, and I'll show more about what are the changes we see with aging. But the key points I want to make here is that you're going to see a lot of inter and intra-individual variability in the changes that are seen with aging. And in particular, changes with what's called fluid intelligence more so than crystallized intelligence. And on the next slides or so, I'm going to explain what's fluid intelligence, how is it different than crystallized intelligence, and I'll show graphically in particular this inter and intra-individual variability. But the key point of this slide is take a group of adults, measure their cognition on some regular basis, take away, though, all those people who meet criteria based on current nosologic standards for disease, take away those people with diseases that would impair cognition, and what you have left are people whose change or lack of change defines what's cognitive aging. So this slide depicts in greater graphic detail the changes that are seen in two categories of our cognitive abilities, our crystallized and our fluid abilities. And I apologize for the layout of this slide. I've had someone point out to me that it's actually confusing, so I'll explain it in a little more detail here. On the far left, you see a graph, a lot of scatter plots spread out over about a 60-year period of what's known as crystallized intelligence. And what this plot is showing is a category of cognitive abilities that essentially capture what's called our knowledge, the things that we learn, our language, our skills. And what I hope you can see here is that over time, there's very little change in our crystallized intelligence. In fact, the line, the summative line there suggests it may actually increase over time. But I hope you also see that the scatter plot shows a lot of variability, that some individuals who are in their 20s have a level of crystallized intelligence that's about as low as some of the individuals in their 80s and vice versa. But the trend here again is gradual increase to static performance over time. In contrast, on the lower right, you see a plot that shows a decline over time. That plot is labeled our fluid abilities. So this is a category of our cognitive abilities that are our ability to actively process new information, particularly in novel situations, to think logically and solve problems. Here what we're talking about is our kind of ability to learn new skills and apply it. And I think the message from the graph that you see here is, over time, our fluid abilities do decline. But again, much like the scatter plot that we saw with crystallized intelligence, there's a lot of variability. So you see here that there are individuals in their 80s whose performance on measures of fluid abilities are as good as the youngsters. So the overall lessons of the last two slides are, if you take away from a cohort all the individuals with diseases that impair cognition, and then measure in those who remain their cognitive abilities, and then follow them over time, what you'll find is, as a group, a steady decline in fluid abilities, a relative stasis or even increase in crystallized abilities or intelligence. And these changes really start right around about the 5th decade. That is to say, in our 50s, or the 6th decade, we start to see individuals show, as a group, decline in their fluid abilities. The next slide addresses some of the sort of problems of terms that are out there. So I've used the term cognitive aging. I've used the term dementia. But what I haven't talked about is normal cognitive aging. I haven't talked about normal aging or normal cognitive aging because I want to provoke you with the point that to denote cognitive aging as normal starts to then create the notion that these changes in cognition, particularly changes in fluid intelligence, are somehow okay. When in fact, actually, the changes that do occur in cognitive aging over time, particularly in fluid intelligence, can actually be problematic, particularly causing problems with individuals to use technology, make decisions under time pressure in novel situations. So, for example, in particular, financial decision-making. Individuals with difficulties with fluid intelligence may have difficulties making financial decisions and therefore make either mistakes and or be the victim of fraud or financial abuse. Another point I want to point out is that statistically normal aging is correct, but I want to kind of emphasize that talking about cognitive aging as well as statistically normal aging is a hard term to message. And what I'm getting at is that it's really, in the report on the Institute of Medicine on cognitive aging, which I'll talk about in a minute, we really avoided the term normal aging. We also avoided the ideas of natural aging and successful aging. And again, I think the problem with terms like normal aging, natural aging, successful aging, is that it says somehow that what's going on is either okay or not a problem, when it may be a problem, it may not be a problem. And so I think kind of a safe, kind of neutral position to take when we talk about cognitive aging is to just talk about cognitive aging. I want to talk about some implications of the definition of cognitive aging. Namely, that when you do a test of cognition, you're just getting a score, a raw score. And what you now need to do is turn that score into, you need to norm it. And because you have to compare that person to other people like them. So in particular, you're interested in comparing people of like education and like social and occupational exposures to other people, so that you don't allow education to be the thing that you're actually measuring instead of cognition. So the point I'm making here is that how we norm cognition reifies into the concept the factors that influence performance on cognitive tests. So this is an interesting issue, which is if I norm cognition for age, for education, social and occupational exposures, I'm saying that those things which may actually influence cognition are part of the normal for that group. It's simply a choice we have to make. Another implication of the definition of cognitive aging gets back to the beginning point about, well, what's dementia? Which is that as our concepts of what are the diseases and syndromes change over time, cognitive aging changes. So, as I said in the beginning, the key take-home point from my remarks is that cognitive aging is defined by what happens after you remove everyone with disease. Well, if you change your notion of what's a disease, you change who's in the pot of those who you think are not diseased. And a good example of that would be the concept of mild cognitive impairment. So now we think of MCI as a diagnosis. I can go over to the Penn Memory Center tomorrow and I can diagnose and bill for people with what's called mild cognitive impairment. They're not demented, but they have a memory complaint, a cognitive complaint that I can measure on cognitive testing. Well, once upon a time, mild cognitive impairment was not mild cognitive impairment. It was not a diagnosis. And so prior cohorts that defined cognitive aging likely included people who had MCI who, in the current contemporary approaches, would not be in cohorts used to define cognitive aging. So the message here is that over time, the norms change, and quite frankly, they should change as we make advances in understanding what's disease and what's not disease. All the more emphasizing the problem of talking about normal aging. So this concept of cognitive aging, it certainly is enmeshed in our biology, but it's also enmeshed in our environment, our habits, our culture, and our concepts of disease. So as these things change, the concept will change. It's probably best assessed within an individual over time, so that as an individual changes over their own time period, they serve as their own norm. This also allows us to incorporate practice effects. Both of these things are important because given the fact that education and occupational exposure can affect how we do on tests, we want someone to sort of show how they're going to change over time in their fluid intelligence rather than saying that their performance is or isn't within normal ranges. Also, practice effects occur when we test people over time. Namely, you repeat the test every year, people do better on the test or they don't do better. And so you want to be able to account for that effect on cognitive testing. And the way to do that for an individual is to, quite frankly, test them over time. Finally, we need to regularly revisit the norms that we use to statistically norm cognition. The exposures in occupation, the quality of education, the exposures of health, the concepts of disease have over the last century changed, and they will continue to change. And so the kinds of individuals that would have been, quote, normal, again, whatever that means, back in 1900 are very different than the kinds of individuals we would have said that that was the case in 2000. And that very well will be the case in 100 years from now. And so we have some almost social policy mandate to revisit who's in the normal cohort on a regular basis, recognizing that the factors that drive concepts of disease and that influence cognition change over time. So I mentioned earlier the report. Namely, I had said that in the report we didn't talk about normal aging or normal cognitive aging, and this is the report. So about a year ago, the Institute of Medicine, then now the National Academy of Medicine, issued a report called Cognitive Aging, Progress in Understanding and Opportunities for Action. This is the web address for it. If you just Google cognitive aging, you'll find this report. It has a couple of, it's a very long, thorough report. I would recommend Chapter 2, which lays out the definition and the measurement of cognitive aging. It also has, as well as the whole report itself, a 4-page brief, action guide, and some other materials that summarize what's in the report. It represents, I think, the current state of the science, state of our knowledge of what is cognitive aging, that I think is the best summary we've got so far on what we know, but also what we don't know and what we need to know. I believe that is the end of my remarks. This is just a slide thanking my support here from the CDC, and I think now I'll turn it over to the next presenter.
Thank you very much, Jason. This is Basha Belza again, the moderator. I really wanted to thank you for that informative and engaging talk that you gave. I also wanted to mention, as far as the Institute of Medicine Cognitive Aging report, I've used those issue briefs, 2 and 4 pagers, geared to the public in talks I've given, and have found them very much of interest to our public, our consumers. So do take a look at the 2 to 4 page PDFs that they have. Okay, well, thank you, Jason. We were going to have a couple of our scholars be our initial responders, and then we'll open it up for other questions or comments. It looks like we have first question here, but before I get to the University of Arizona one, perhaps Kate from University of South Carolina, did you want to make some remarks? Please feel free to introduce yourself as one of our HVRN scholars.
Sure. Hello, my name is Kate Olskamp. I am a master's in public health student here at the Arnold School of Public Health. And one of the things that we, me specifically, but also the group here at South Carolina is interested in is public perceptions, both in terms of families and caretakers, but then even the perceptions within the medical community. And one of the things I was thinking as you were speaking was this issue of lack of clarity, probably especially among the public. And in your experience or research, what sort of problems does this create? Does it change access to treatment? Is there the assumption that people don't need treatment because things may or may not be considered normal in their understanding?
So the question is how the term cognitive aging or the term normal cognition or normal for aging may or may not influence people's behaviors. I don't have empirical data to speak to that issue. My suspicion is you all might. I welcome you to say that, to speak up, volunteer that. I think, though, it only follows that if you do say to someone, well, your changes are normal, you then engender the notion that what they're experiencing is in some sense almost, not real, or at least not the object of any need for public attention, either by the healthcare system or the public health system. And I guess my message is I don't want to medicalize the changes seen with cognitive aging, but on the other hand, they are real, and for some people can cause some real troubles with not just symptoms, but the ability to perform activities, and therefore I think need to be acknowledged.
Thanks, Jason. This is Basha again, and I wanted to put forward a comment and a question to you. This is from Anna Stoker, who's one of our scholars from University of Arizona. She thanks you for a great presentation. She's been researching the use of antipsychotics to treat behavioral symptoms of dementia, so this was very interesting for her to learn more about dementia and cognitive aging. Her question for you, Jason, is how does dementia affect crystallized and fluid abilities? Are they equally affected?
So it depends on the cause of dementia. So let's focus, say, on dementia caused by Alzheimer's. So in dementia caused by Alzheimer's disease, the earliest signs and symptoms are troubles with episodic memory, the ability to remember new information, and the ability to plan and concentrate, and particularly changes in executive function. So both of those abilities describe cognitive skills that largely fit into our fluid intelligence. Over time, though, as people develop Alzheimer's disease, as it worsens, you start to see changes also in crystallized intelligence. They start to lose semantic knowledge, for example. They lose the meaning of words. They lose the ability to do certain tasks that they've learned. And again, so each dementia presents in a different way in its beginning stages in terms of the kinds of cognitive abilities that are typically affected and the trajectory of change. I think the key issue is that, by definition, if I diagnose someone with dementia, they're not in the group of people that would define cognitive aging, and they, quote, don't have cognitive aging, because cognitive aging is defined by those who are not demented. So we get caught up somewhat in the definitional issue here, because, as I said earlier, with cognitive aging, it's possible to have troubles doing activities of daily living, given those changes in fluid intelligence, but the person just doesn't meet the severity for the history and the physical and other findings to meet criteria for dementia.
Thank you, Jason. We have another question from one of our scholars at University of Washington, Sheehan Lin. She's one of our PhD in nursing students, and she was a scholar that started with us last year. And this is her question, Jason, to you. I'm wondering if it would be okay to say that cognitive change is normal for people your age, so make it age norms. I think some older adults, she goes on to say, really would like to be assured that their cognitive performance is with the, quote, normal range, even though you may not feel normal when the comparison is made. So how do you talk to your patients who are having cognitive changes? Yeah.
It's an interesting question. So I'll say some work we're doing in individuals who are cognitively normal who learn that they have an amyloid marker seen on PET imaging that's suggestive of subsequent development of Alzheimer's. Many of them talk about feeling normal for people like them. There's a lot of age norming for their cohort, the people who are like me. So I think culturally people do that. Well, what am I like compared to people like me? And I have no judgment on that. I mean, that's what people do. And I do, and we do norm cognition for age. We do. Because if you didn't, and you said, for example, that normal cognition was, say, at age 50, you'd essentially be guaranteeing that people by their 80s would have, quote, abnormal cognition because you're using the performance of 50-year-olds as your normal comparison group. And that's, so to avoid that, you norm to people who are your age and also otherwise healthy. The problem, what you're doing if you do that is you're essentially kind of slightly forgiving the changes that are seen with aging over time. And so this is a choice really that's made about to what group do you norm people. Getting back to the question, I think that people kind of want to know, well, how do I compare to people like me? And people like me are people my age. But just to provoke the questioner, there are other diseases where we don't norm standards of normal to age or other conditions. So, for example, bone mineral density is not normed to people your age. It's normed to someone whose peak bone mineral density is around their third decade of life. And so that just reflects a choice in terms of what do you want to use the measurement for. Is it to predict risk, in which case you wouldn't want to maybe norm to age, or is it to norm to age because you don't worry about, for example, or you're not concerned about predicting risk?
Very interesting. Thank you. Did we have any other, and Sheehan thanks you too, did we have any other comments, either observations or questions from our attendees? Well, thank you, Jason, for getting us started. This is great. This serves as a great foundation then for our next two presenters. It's really a joy to work with you within the Healthy Brain Research Network, and we really appreciate all you and your colleagues' mentoring of scholars at University of Pennsylvania. Okay, it's my pleasure now to introduce our second of our three speakers, Dr. Friedman. Daniela Friedman is an associate professor in the Department of Health Promotion, Education and Behavior at the University of South Carolina. She too and her colleagues have been doing a wonderful job at both recruiting and mentoring our Healthy Brain Research Network scholars. So it's my pleasure to turn it over to Daniela.
Great, thank you very much, Basha and Gwen, and hopefully everybody can hear me. So excited to present on today's webinar and excited to tell you about everything that people know and think about cognitive aging in 10 minutes or less. So I don't think we'll cover everything. But as Kate said, we're very interested here at our HBRN site at looking at people's perception about cognitive aging. And we've been asking people over several years what their perceptions are regarding cognitive health and cognitive impairment. So today I'll talk briefly about research that we've done, and we did 3 different studies. One was a large qualitative study across the U.S., one involved contributing questions to national survey research, and one was a scoping review of the literature. And through these different studies, we have compiled a lot of interesting data on people's perceptions about cognitive health and cognitive impairment. The first study that we refer to as our Healthy Brain Study involved conducting over 80 focus groups with over 616 participants across the U.S. and specifically across 9 states that were funded by CDC's Healthy Aging Program, through the Healthy Aging Research Network grant that preceded the Healthy Brain Research Network. Focus groups were conducted between 2005 and 2009, and we conducted the focus groups with diverse audiences, including older adults in rural and urban locations, as well as individuals from different racial ethnic groups, caregivers, as well as healthcare providers, both primary care physicians and nurse practitioners. So to give you some ideas about older adults' perceptions about cognitive health and cognitive decline, they were concerned, families were concerned. When asked what they thought they could do to maintain cognitive health, they talked about lifestyle factors, including physical activity, diet, staying socially engaged, mentally active, and they also mentioned spirituality. And it's interesting to, you can see the terms here that people used, including I need to do these things to stay sharp or to be right in the mind. So it's been very interesting to see the type of terms and the nomenclature that is being used in the community, a little bit different than what's being used on the scientific side. Different cultures emphasize different aspects of cognition, and they focused on different things. Some groups talked a bit more about spirituality than others, and people had some different ideas about types of physical activity, types of social activities that would help, etc. Majority of folks talked about mixed messages that they heard in the media and wondered what was accurate from the information that they heard about ways to maintain their cognitive health. When we spoke with caregivers focused a lot on the symptoms of the person that they cared for who had dementia, and they also talked a lot about their own coping strategies. And what they could do to maintain their brain and exercise the brain, and they talked a lot about being active. So that's what we heard from a lot of the caregivers that we spoke with. We also talked with providers, and as I mentioned, both primary care physicians and nurse practitioners. And what we heard during interviews and focus groups with these providers were that they weren't talking too much about cognition in their discussions and interactions, though they recognized the benefits to the cognitive benefits of the overall general health recommendations that they were making with patients. And so this quote from one provider indicates that they never really initiated the conversation when the patient didn't ask, or when it was obvious that there was something going on, they did talk about it. But other than that, they didn't really have too much time and felt like they were going to get at it if they discussed general health information and recommendations. After we did our focus group data, we wanted to take this and look at some survey data and what we could do to talk with both consumers and providers at a national level. And so with the CDC Healthy Aging Program, we had the opportunity to submit questions focused on cognition and people's perceptions about cognitive health and impairment, and submit these to the National Porter Novelli surveys. Doc Styles is a survey that's intended for providers, and Health Styles is a survey for consumers and the community for individuals 18 and older. So findings were very interesting. Providers reported advising patients about reducing risk of cognitive impairment. On the consumer survey, consumers reported receiving this information from other sources. And so it's interesting, different perceptions about communication as well. And so we hope to explore this a little bit further and see what types of discrepancies there may be between the patients and providers in that way. This table, I hope everyone can see it on the slide. This is looking at and comparing consumers' perceptions about ways to maintain cognitive health and reduce cognitive impairment, and then what advice providers gave to consumers about what to do to maintain cognitive health and reduce cognitive impairment. So consumers thought that being physically active was very important. That's that green box that you can see right there. And physicians and nurse practitioners, quite a few of them on the survey also indicated that they talked with their patients about physical activity. If you look at the blue box below that, eating a healthy diet was mentioned by 82.5% of consumers, and then slightly lower percent of physicians and nurse practitioners, but still discussed being socially active. I've highlighted that here as well. And then I've highlighted the vitamins and supplements. I thought that was interesting that the consumers perceive that vitamins and supplements could maintain cognitive health. There isn't the literature necessarily to support that, which is why probably the physicians and nurse practitioners didn't necessarily talk about vitamins and supplements specifically in relation to cognitive health. Then we moved on. We did our large qualitative study, and we've done the national, submitted questions to those national surveys. And then we wanted to look even more at empirical literature and more recent studies that were done looking at the public's perceptions about cognition. And this review, I think, really helped inform actions of the 2013 roadmap that's focused on cognition. And we can provide a link to that as well, and that was developed by the CDC and the Alzheimer's Association and other partners. We reviewed over 1,000 abstracts, and then in the end looked at 34 studies that looked at perceptions about cognitive health and cognitive impairment. You'll see where the studies were conducted in 8 countries, and participant numbers really varied in these studies. You can see some studies looked at perceptions of 9 people in interviews, and then there were some national surveys that looked at some national surveys with large numbers. Most studies looked specifically at dementia and Alzheimer's disease. And across the studies, you'll see here the top 2 risk factors that were mentioned across studies, and then top 3 protective factors that were mentioned by people that they thought could protect, help people maintain cognitive health. So we're seeing the same lifestyle factors and other risk factors here that we found in the previous study. So it's interesting to see that consistency across time. Even after the more recent reports were released. So just to summarize some of those findings of the scoping review, the public, regardless of where the study was conducted, or race, ethnicity, or gender, people identified pretty well-established risk factors for cognitive impairment, and also factors that may reduce risk. And here's a quote from one of the articles, or a qualitative one that we reviewed that you can take a look at. If you stay indoors and don't get out, your mind will slow down. When you have time, even if you just chat with your friends, Not sure if you can still hear me.
Okay, you're back, Daniela.
Okay, that's great. I can't see the screen, but I can. That's good that the microphone is working.
Okay, I think we lost Daniela there.
Okay. Basha, are you able to hear me?
Yes. I can hear you now, Daniela. Thank you. And the slide we have up is your scoping review findings.
Okay, great. Well, I can't see the slides, but I'm just going to move forward if that's okay.
Okay. How about Gwen, you take over, and now we have scoping review findings also.
Okay, that's great. And so just to summarize what this study showed us is that participants across these studies really identified the established risk factors and protective factors. We found that investigators were not really using or investigating consistent factors across studies, though, and really just asking participants what they thought about ways that they could maintain cognitive health or to reduce their risk. And so in order to kind of look at perceptions in a more systematic way, it might be helpful for us to actually be incorporating and asking participants about the same list of risk factors and protective factors across studies. The last slide that's there that maybe, Gwen, that you can show, it talks about the use of different terms, and I think it has the word nomenclature at the top, and it has different years and some terms that we've submitted to surveys, and just looking at terms across time. It's probably the second last slide there before it has the acknowledgments.
And we have that, Daniela.
Wonderful, wonderful. It's a good thing I memorized it. And so I just thought this was interesting. You know, this webinar is about terms and defining cognitive aging, and now thinking about how people perceive cognitive aging and cognitive health and impairment. And so these are terms that we've used on surveys and that we've seen on other surveys to meet people where they are and how they're using terms. So staying sharp, maintaining, keeping our memory. These are terms that we've used and heard community members say, whereas surveys that we have used where we are working with professionals and healthcare providers, we've used terms like reducing cognitive impairment, risk of dementia, and terms like that. So I think there's still work to be done in how we use our terms, and I think the report that has just come out that Dr. Karlawish talked about around cognitive aging is really excellent and will help us moving forward in the research that we're doing, and also help to bridge that with the community and in how we talk about these issues. So thank you very much, and thanks, Gwen, for advancing those slides. Sorry, I'm just not able to see them.
Thank you very much, Danielle. This is back to Basha Belza, the moderator. Danielle, we really appreciate that informative presentation and really feel that it builds nicely on what Jason just presented. I would invite all our attendees to put any questions or comments in the chat box. Meanwhile, Danielle, I wanted to ask you this whole piece about consumers and their interactions with various healthcare providers, and you had pulled out physicians and nurse practitioners. I'm curious to know whether we have any work as far as physical therapists. We're starting to do some work with physical therapists here at University of Washington, not related to the Healthy Brain, but in relationship to referrals to evidence-based physical activity programs. But one of the things we find is physical therapists are a trusted provider, realizing not everybody sees physical therapists, but has there been other work in looking at other types of care providers than just physicians and nurse practitioners in relationship to querying folks about cognitive aging?
Gosh, I think that's an excellent question. I don't have any data or articles around that, but I think that's very fitting, especially when a lot of the evidence on protective factors is around physical activity. So involving physical therapists in these discussions and in this type of survey research, I think, would be excellent. We focused on sort of those primary providers in that initial survey research because we wanted to see what was being discussed before any referrals were being made. In other areas, we have worked with specialists, but not in the area of cognition and aging. So I think that's very interesting, and it would be interesting to share some of the questions that we've used with the other providers to see how they would translate and work in the work that you're doing with the PTs.
I'm reminded, too, because our Healthy Brain Research Network scholars are a wonderful group of multidisciplinary, both undergraduate and graduate students. And so I think our scholars bring a rich diversity as far as their discipline training to this whole area of cognitive health. Okay. Any other questions or comments from the group? If you wanted to add them to your chat box that we could then share with Dr. Friedman.
And I'd be pleased to share any of the articles or any of the types of questions that we used in our focus groups or on the surveys as well following the webinar.
Thank you, Daniela. You are most generous. Really appreciate that. Okay, well, it looks like we have someone typing, and it looks like you've logged into another computer, so you can actually see the slides then, too. Okay, and Daniela, it looks like we are going to have a question or comment from Jason, so hold on one moment, please. Okay, we have a question from Melissa Fessel. Melissa is a nursing, Doctor of Nursing Practice student here at University of Washington. She too is a Healthy Brain Research Network scholar. And this is her question for you, Daniela. The multifactorial risk factors associated with cognitive aging are described in the recent IOM report. I'm wondering if you found any differences between studies focusing on a single domain versus multiple domain interventions. And that question actually, Daniela, feel free to answer that, or if Jason, you're still with us and you want to respond to that, that would be okay too.
This is Daniela. Hope you can hear me, and that's an excellent
Yes.
question, Melissa. I wouldn't say that there were any differences that stand out from me in those 34 studies that we reviewed for the scoping review. Many of them asked about multiple factors, but a lot of the studies, it was that they were often. So, you know, do you think that any of these factors can protect against cognitive decline? And there would be a list. Or that participants just offered a number of factors. So I don't think that really much, we didn't do much work to look at differences between studies that, that may just have focused on one, because I don't think that there were too many of them, and I'm not sure if even the ones with looking at multiple factors were necessarily that systematic, if that makes sense.
Thank you,
It's
Daniela.
Jason.
Oh, yes, please, Jason.
So I would urge the questioner to have a look at the FINGER study out of Finland, and the FIN stands for Finnish or Finland, and it is has rolled out some data from an intervention that involves exercise, diet, and perhaps other components in an effort to decrease the changes seen over time in cognition in otherwise healthy older adults. And they've reported out data that suggests that multifactorial intervention does change the trajectory of cognitive change over time. And it's an example of a multifactorial study in terms of the intervention as opposed to trying to isolate interventions. It's, again, the FINGER study, and it's ongoing, but has recently rolled out some data from its, I think, 2 or 3 year endpoint moment.
Excellent resource. Thanks, Jason. And thanks, Melissa, for asking that question. We have another question from Kristen. Kristen is at University of Pennsylvania. Kristen Harkins asks you, I'm wondering if a particular terminology emerged that you found bridged the gap between the language used by providers and what resonates with older adults and their concerns.
That's a great question. I think we've looked at it separately, speaking with community and then seeing what term providers are using. We've talked about this among the members of the Healthy Brain Research Network as well, and thinking about terms such as memory loss is one that we thought, well, maybe this is what we should be using, but you know, that could refer to so many different things. I'm sure, you know, Jason can speak more about that.
It sounds like we lost Daniela again. While we wait for her to come back, we did see that Melissa actually just completed a review of looking at multiple versus single domain studies, and actually, Jason, she is familiar with that particular study, as she did complete the scoping review. That was part of her HBRN Scholar project, and actually has submitted it for consideration for publication. So it's very nice for her to have that reinforcement from you as far as that being an important study.
This is Daniela.
Okay, Daniela, do we have
Yes,
you back?
Thank you. And just back to the question about what term to use. When we did our work, we were focused quite a bit on the terms cognitive health and cognitive impairment. So I think listening to the next presentation may help to answer the question, because I know in some of the qualitative work that we're going to hear about, the term cognitive aging, I believe, was used. So that will be interesting to hear perceptions of more current terms, I guess.
Okay, well, that's a wonderful segue. Thank you very much, Daniela, for offering that segue to our next presentation. This is our third of our three presentations. Andre Pruitt is a social worker and is at Oregon Health and Science University. He too is one of our Healthy Brain Research Network scholars, so we're real pleased that he is presenting on this call, and he is joined with his colleagues, Dr. Raina Croft and Dr. Linda Boise, also from Oregon Health and Science University. And again, my thanks to all our colleagues at Oregon Health Science University that do work with our scholars. I'm really excited, Andre, to hear about some of your work. So I will turn it over to you now.
Great, and thank you so much for allowing me to share today. The three of us are going to be talking about how African Americans are making meaning of caregiving and cognitive impairment. It was based on the breakfast focus group, and the project is part of the Oregon Health Brain Research Network Collaborative, as well as collaborating with and to enhance analysis by the Oregon Department of Aging and Disability Services in the Health Department. We conducted 4 focus groups with African Americans in Oregon from the ages of 45 and older. Now, the rationale for the focus group is that the behavioral risk factors surveyed by the CDC and the telephone survey that we used was conducted in 1988, and in 2012, Oregon added the cognitive impairment and caregiving modules. The information that we were gathering from the telephone surveys did not include sufficient numbers of African Americans based on the population in Oregon, so that we had lacked some effective information to do some quality information. And so we decided to do quality focus groups to collect that data. The data we wanted to use was to reflect the African American experience and understanding of cognitive impairment and caregiving, and to learn how they understand the survey terms related to cognitive health, such as Alzheimer's and dementia, and cognitive changes, and if there was some similarities of understanding in those terminologies. Some of the settings that we worked with were churches that we participated in, as well as participants' homes and community centers, service centers. One of the areas that was kind of unique is that a group of women were gathering together on a regular basis and meeting in a restaurant. So they had one of the researches that we had focus group was held in one of those venues at the restaurant. We used flyers and the snowball sampling to recruit people to participate. And the nice thing about after we had the very first focus group, people were so excited about participating in this research, they began to tell other folks. And so we began to communicate with other people to join the focus groups. Community leaders also participating as far as formal community leaders and informal community leaders, as well as different personal contacts and church leaders were all invited in to participate within the focus group. The focus group we started off was using a survey from briefers that asked some certain questions, such as personal experience of cognitive impairment during the past 12 months. We followed that survey and then led into more discussion to go deeper into some of those questions. Some of the other questions that came from the survey were like, have you cared for someone with cognitive impairment in the past month? One of the things that we did notice is that even though we talked about the past month, that several folks also talked about caregiving in the past year or two, and so we began to go more into depth around that during the discussions. The second part of the focus group was semi-structured interview questions that went a little bit deeper from the Burford survey and talking about confusion, memory loss, as well as Alzheimer's disease and dementia. We also explored experience with cognitive impairment and how caregivers impacted their lives. With the study participants, we found that 37% in the past month have provided care. We also noticed that 78% provided care in the past 2 years. That out of 10 out of the 30%, 10 participants talked about providing 40 hours of care or more per week. What was nice to notice is that 14 people were retired and that 13 folks were either full-time employment, part-time or self-employed. Education was quite high. 11 participants were masters or higher. And you notice that 8 were graduate of high school or 4 years of college. 1 to 9 had 1 to 3 years of college or technical school. And we talked about the housing piece. 23 people owned their home, and 7 folks rented. The process that we did was, as you notice here on the slide, we talked about our code for the key. And the nice thing about the developing the code, we each one of us, Raina, myself, and Linda, coded the first focus group. And then we got together and we discussed our similarities and some of our differences and came up with a common code that we went back and recoded to make sure that the new codes that we came up with actually fit with some of the findings that we had. And we came back and talked about it again. We did this about 5 times, and we finally came up with this final code that you see here that we were able to code the transcripts. So from some of the preliminary results, we had some conceptual meetings and cognitive changes, and we noticed that there was uncertainty of cognitive changes, memory loss, or dementia, and Alzheimer's. But people had different viewpoints of that, and there was some confusion of what some of the definitions meant, and if someone was having the symptoms of normal cognitive changes, they were thinking they had severe Alzheimer's disease, and so we had realized there was some discussion around that. Some of the other conceptual meanings was consistent about losing space and time. And we talked about losing space and time. People would forget days, they would forget hours, or they would forget the space, the place that they were living in. And so we talked about that as well. We also realized that through some of the preliminary findings, talked about how people were coming face to face with symptoms of oppression, where we looked at where people were getting different kinds of care based on your economics, based on your insurance, and some people talked about some experiences dealing with cultural stuff based on their race. We also there was also a discussion around experience of trauma and how this impact of memory loss, cognitive changes, or dementia or Alzheimer's was really traumatizing to some of the family. You know, they would see the family as being healthy, and then all of a sudden it seemed like overnight changes happened and how it impacted the entire family. There was a variety of experience of providing care throughout the surveys, or excuse me, throughout the focus groups. Some of the preliminary results were training that was needed. Some of the training that they thought about was specifically around the African American community about talking about what is Alzheimer's, what is dementia, what are some of the services that are provided within the community. Especially when we have 2 major areas that we worked in. One was in Salem and Portland, and the people in the Salem talked about how there was some services in the area, but they realized that a majority of people didn't know about some of those services, and that there was some more and trainings that needed to explain what services were available in that community. They also talked about wanting empathetic training for providers as well as family members who are caring for those who have cognitive impairment. We also wanted more training around what are the symptoms and understanding what is happening to the individual. What are some of the characteristics that are occurring when we see some of the changes that are happening. They also wanted training around what is the definition between Alzheimer's and dementia. Are they similar? Are they different? And what are those differences? There was a huge group of pastors and lay folks who were asking for specific trainings that were within the churches so they can actually talk with people who are experiencing memory loss or cognitive changes, and so that they can provide some support around that. Do you guys want to add anything to that? And then for carers, how to take care of themselves. One thing that was very evident is that because of the lack of information around the services, people who were providing care were not being able to tap into some of those resources, and so they were finding experience of being burnt out and going through this all alone. So they wanted ways to have training about how to take care of yourself when you work with a family member or loved one who is dealing with memory loss, cognitive changes, or Alzheimer's. And then training for medical professionals on bedside manner, how to effectively work with folks who are dealing with that in a culturally responsive way, and to understand some of the impact that people have to some of the oppression, so that when we're doing some work, that they have that support and understanding around those situations. And that is it.
This is Raina. I'd like to add that as we were talking about the experience of caregiving, we realized we had to back up and really get a better understanding of what caregiving meant to people, and that it was a really wide definition. We had a definition as far as being supportive and driving someone to their appointment, to the full-on caregiving that most of us think of when they have to do quite a bit for their loved one. So that was interesting to see the range in ideas of what caregiving meant. And we also found that sometimes we would use the term caregiver burden, and we found that that was not an appreciated term, that people really felt that this was an honor to be caring for their elders, and that this was a really strong point in the African American community that should be celebrated. And it felt like people really saw caregiving in its wide definition for their elders as something to celebrate, but yet still needed to be recognized the toll that it takes on the caregivers.
So this is Linda here, and I'm going to go back to the slide right before this one. On the right-hand side, I think one of the things that and it goes along with what Raina was saying, is that one thing that we noticed as people were talking, at least in several of the groups, and we need to do further analysis of all the groups to see if this is really replicated in the other groups, but that when we asked about resources, some people really focused initially on themselves and as individuals, and talked about being proactive, and then also talked about, working with family, reaching out with family. I think one of the things that struck me particularly about this group is the wide range of knowledge and understanding about formal services, as well as the ways that some of the people were actually working with family members. One person particularly mentioned holding family meetings, and it was pretty amazing to hear her talk about how they called family members together to talk about things that they saw happening and changes that they were anticipating in a particular family member. Even to the extent where in this particular group they agreed to pool some money. So each individual that was involved in this discussion pooled money, put it aside so that it would be available for future needs as they came about. So that was a really amazing example. I think in terms of knowledge of services, there was a pretty wide range. We had people listed many, many different kinds of services, but there were also some people who really knew very, very little about what was out there. One implication of that, I think, is if you can bring people together like this, people learn from each other. And that's a pretty exciting thing to see.
Well, thank you very much.
Yeah.
Thank you, Andre, Linda, and Raina. Great. Nice to have a team approach to your presentation, and really, really interesting is hear both your methods as well as your results and what the implications are. We have a question from our colleagues at University of South Carolina regarding training. Did the community members mention anything about specific partners for the trainings and the training content?
Well, there was from my understanding, there was a variety of requests, and they weren't thinking about what the partners were. They were more thinking about getting training around what dementia was, what are the healthcare services, and how to network so they can be more productive when they're providing care for their loved ones.
Thank you. I know Lynn from University of Washington was also going to serve as a respondent here. Xian, were you going to do that verbally, or were you going to do in a chat box? I see a chat box from you. Okay, thank you. She is, again, one of our scholars here at University of Washington, and this is her comment for you, Andre, Linda, and Raina. I'm curious if any of the participants asked for clarification of the differences between memory loss, dementia, Alzheimer's, and other like terms during the focus groups. I'm curious how the focus group leader facilitated the discussion without influencing the participants' perceptions of what and how or what these terms really mean. Excellent question.
That is a great question, and yes, that did occur. And what happened was we tell them when we get done discussing, we will give you some information, but we wanted to find out what you had meaning first. And so before we even explain what the terminologies were, we waited till everybody talked about their point of view first. And once that was done, then we gave some information. And that question happened in every focus group.
Yeah, that's really interesting. I think that's something common we face when we go in, structure these focus groups and want to query the participants about a certain phenomena, but how do we present it in which we don't bias them with it in advance? So I like your approach of first asking their thoughts and then afterwards providing some information. So thank you. Really, really appreciate that approach, Andre. And
I might...
Go ahead, Linda.
Yeah, I just might add that particular topic was very dominant in all of the groups. And there was a lot of discussion about that and a lot of questions. And when we asked people what they thought about, particularly what's the difference between Alzheimer's and dementia, we got answers all over the map. So that was really pretty interesting to hear. And, we'll be working more with that information as we go forward. But I think I'm interested also in putting out a question to everybody listening, which is, what difference does it make as professionals working in this field whether people understand the difference between dementia and Alzheimer's disease?
What difference does it make if the lay public, is that who you're referring to?
Yes.
Not health professionals, but whether our communities know the difference between these terms.
Yes, and how much effort should we be put into trying to make that really perfectly clear to people? Because it was really clear from these questions that it was not clear.
Well, I think we could think from a public health perspective. It's Jason Karlawish at Penn, that the difference matters, because if we have a concept of Alzheimer's, for example, that includes people who are not demented, then if people fail to see the difference between the two, they are going to have a hard time understanding how are you labeling people with Alzheimer's who aren't demented. And the second challenge you would face from a public health perspective is that you would be kind of subsuming all dementias under the label of Alzheimer's, when in fact Alzheimer's is not the only cause of dementia. And so I think the distinction matters in order to advance a prevention message, as well as to distinguish amongst the different causes of cognitive impairment, because even if you were able to eliminate Alzheimer's as a cause, you'll still have cognitive impairment with aging.
Thank you, Jason. And I think your comments are reinforced by several of our other attendees who are making similar comments in the chat room there. Andre, we did have another question about how these results will be shared back with the communities that participated in the focus groups.
Yes, well, the plan is to, in fact, I'm getting ready to send out an information letter to let people know that we are starting to analyze the data, then we're going to actually go back to the community with the results and share. So that's the plan that I know as of now, that I'll be back and sharing the results.
This is Raina. We will also use the information we get from these focus groups in terms of how people understood the terminology to help inform any messaging that we want to do for these communities going forward.
One that was was very powerful to get the participation of folks in these focus groups was the commitment to come back with the findings and to come back to the community so they can empower the community to move forward and design what they think they need in order to support people in their communities dealing with memory loss, cognitive issues.
Mm-hmm. Mm-hmm. And going back to the previous question about the importance of differentiating and helping the public understand these terms, Macy Smith also makes the comment that better understanding of the disease and the symptoms empowers the caregiver to better care for their partners. So there's an empowerment piece here and the relationship between the caregiver and their family members. There's another follow-up question from Sheehan. If the research team realized that most of the participants cannot distinguish the differences between the terms, do you think it would be the research team's responsibility to provide educational materials or direct them to available resources? So I think this is a really good question that many of us face in research is identifying when the public or our clients, our study participants have a different working knowledge than what's in science. If I'm understanding that correctly, Sheehan. Andre, Raina, or Linda, did you want to comment as far as the responsibility of the research team in this situation? As far as you provide education.
I really do believe it is.
Yeah.
Yes, I really do believe it is the responsibility of the research team to not go in there and leave people with questions about, well, what is the difference, and not respond if we can shed some light on that. So we came prepared with brochures and materials and resources that they could use to better understand that. Also, we gave our own definitions as well, based on our understanding as professionals in this field. But also, we're using these. We're using how they understand the terminology, as I mentioned, to go forward with messaging. And within that is we are developing learning sessions that are specifically targeted to the African American community here in Oregon. Around brain health and how to speak to your doctor and other issues that relate to healthier aging and healthy cognitive aging. And we will be able to start off with a baseline of understanding how other people understand some of the professional terms we've been using, and so that right away we'll be on the same footing with participants in really drawing them in to understand from their perspective and their framework rather than from our researcher framework.
Mm-hmm, mm-hmm. Well, and I think you were really astute to plan this in advance. So many of us, in thinking about scheduling focus groups, we think about, well, how much time do we need for the interview guide, for our questions, and really being savvy. I think we also need to allow time during our focus groups, and whether that means scheduling the room or scheduling our moderators, such that we have time, like you said, to share those resources. We hear from USC that in some of their work, they've actually followed up after focus groups and distributed plain language briefs and also held community forums so as to bring people back together again. So the focus group isn't just an isolated event, but that those participants then would be invited back again around a similar topic. And again, USC agrees that then providing these relevant resources and mobilizing the information is key. So thank you very much, Daniela and Kate, for those comments. And Sheehan also thanks you all for sharing your experience addressing this issue, and I think it's one that many of us face. Any other questions or comments then for Andre, Raina, and Linda? I think this was really informative, and a round of applause, Andre, for being our first HBRN scholar presenting on our inaugural HBRN webinar. So thank you very much. And again, Linda and Raina, thank you to you both for your mentoring. So if we were all in a room together, I would invite you all to do a round of applause for our 3, 4, 5 speakers. This has been really informative. I think it really helps us move forward as far as as understanding the terminology we use and some of the issues and dynamics associated with that across a number of different populations here. So again, my sincere thank you, and all the attendees thank our presenters. In closing, I did want to announce to you that we're excited that one of our partners, the Alzheimer's Association, will be offering travel scholarships to our HBRN scholars. This will be this year only. There's funding to support up to 8 HBRN scholarships at $1,000 each, and this will be able to help offset travel and meeting expenses. So this is for attendance and presentation at professional meetings, and/or our Healthy Brain Research Network is actually having an in-person meeting in November at the front end of GSA, so that will be November 16th. Your applications with a letter of recommendation from your mentor would be due to the Alzheimer's Association by July 15th. So this was just a heads up. We really appreciate our collaboration with the Alzheimer's Association. Molly French has been spearheading this scholarship application process, and she will be sending out a full announcement next week. So that will come from Gwen via our HBRN listserv. So please do look forward to that announcement. There will be additional information about who is eligible and what kind of information you need to apply. But I really encourage all of our scholars to consider applying. It's a wonderful opportunity for you to present your work at national meetings and/or come meet in person with us as far as the Healthy Brain Research Network in-person meeting on November 16th. So stay tuned for that. And again, that release will be next week with a deadline by July 15th. I wanted to particularly thank our HBRN Scholars Work Group that's led by both Rebecca Logsdon here at University of Washington and Daniela Friedman at University of South Carolina, and the rest of the Scholars Work Group for planning this webinar. It's been very engaging. We will send out a link to an evaluation later this week, so look forward to that, and we really do welcome your feedback as far as what you really liked, as well as any suggested changes that you would have for any future webinars. So I wanted to thank you on behalf of the Healthy Brain Research Network for joining us. We really do wish you well in all your efforts to advance our understanding of cognitive aging and cognitive impairment within a public health context. So thank you, and we wish you all a very good afternoon. Goodbye.